So this is a young, fit patient who received standard chemoimmunotherapy with fludarabine, cyclophosphamide, and rituximab, achieved a complete remission. We know that from our data at MD Anderson and other data, including the German CLL study group, the complete remission rate overall is about 50 to 70%. We've reported 70%. Matt, your group has also worked with FCR and shown a similarly high complete remission rate. We're monitoring more closely these days minimal residual disease and minimal residual disease status. Maybe, Nitin, you can comment on, with standard FCR in a patient who has these prognostic features, particularly a mutated V gene and trisomy 12, what do we expect to see in terms of MRD negative rate and complete remission rate?
Yeah, so with the mutated V gene, with the use of frontline FCR, after our group reported that after 3 cycles of FCR, if you were to do a bone marrow MRD negativity, check for bone marrow MRD negativity, typically it's around 25%. However, when the patient gets 6 cycles of FCR, which is the standard duration, approximately 50% of the patients are MRD negative in the bone marrow. So there is another 50% of the patients will be still MRD positive at the time of when they complete the FCR. As you mentioned, the complete response rate, however, generally in our hand was close to 70% for these patients.
And what's the relevance of achieving a complete remission for a mutated case with FCR? The long-term follow-up data that we've reported and that the Germans have reported.
Right, so for patients the data reported from our center, the patients who are mutated for V gene who receive frontline FCR, the median progression-free survival, the progression-free survival actually at 10 plus years was upward of 50 to 55% range. So these are the patients who got 6 cycles of FCR, they have mutated V gene, and then they are progression-free 10 plus years down the line. So that's a very favorable outcome. And the similar data with a shorter follow-up has been reported by the German CLL study group, as well as by the Davide Rossi from the Italian group cohort. So that's a group of patients where I think there is a thinking in our group and others that the chemoimmunotherapy in the frontline setting has a role for patients with mutated V gene who do not have deletion 17p.
The same plateau, I don't think, has been demonstrated on the BR curve by the German CLL study group in the randomized BR versus FCR trial. And we've done a prognostic factor, prospective evaluation of prognostic features, MRD status with FCR, and certainly those patients who have a mutated V gene, who are MRD negative at response assessment in the bone marrow, have a better progression-free survival than anybody else. Patients who are mutated, who are still MRD positive, will tend to relapse and have a shorter progression-free survival. So in terms of our program, and we'll talk about Matt's program also at the Dana-Farber, what direction are we going in terms of new chemoimmunotherapy regimens, and what are we trying to achieve for those patients?
Right, so we, a couple of years ago now, we thought of how we can modify the current FCR regimen, which has been our standard of care for the last decade, maybe more than a decade. And what we realized that there were a few things. One was, as was discussed, that the patients with the mutated V gene are the patients who have the best long-term outcomes with these patients. So we felt that in the new version of the clinical trial, we elected to only include patients who have mutated V gene and without deletion 17p, because that's not where the chemotherapy has any role, in my opinion. And then the CLL11 study had shown that if you compare obinutuzumab with plus chlorambucil versus rituximab plus chlorambucil, there was a better progression-free survival and overall survival for the obinutuzumab arm. So based on that data, we felt that obinutuzumab may be a better CD20 antibody compared to rituximab. And then we also elected to use ibrutinib with a time-defined duration for 1 year in this regimen, based on the Helios trial and others where it was shown to be effective and lead to a higher MRD negativity rate when combined with chemotherapy. So we have this ongoing clinical trial right now at MD Anderson. We call this iFCG regimen. We reported the data at the ASH meeting this past year, where we treated 32 patients with the regimen, and 8 of those patients had completed the 3 courses. So the other important aspect of this regimen is that we are only using 3 cycles of chemotherapy. So it's not 6 cycles of chemotherapy, only 3 cycles of chemotherapy. Patients after that, depending on the MRD status, continue to get ibrutinib plus obinutuzumab for up to 1 year. And at 1 year, if the patient is MRD negative, they will stop all therapy, including ibrutinib, and will be monitored just for MRD recurrence. So at the time of this report, what we found was that at 3 months, after 3 cycles of iFCG, when we do a bone marrow, the 86% of the patients were MRD negative. Now, this seems favorable compared to our historical FCR data, where at the same time point, for the same patient population, the MRD negative rate was 26%, which we reported, our group reported several years ago. So based on that, it looks favorable. And at the time of the ASH presentation, we had 12 patients who have reached 1 year time point. All 12 patients were MRD negative in the bone marrow and had stopped ibrutinib. And none of these patients had a recurrence so far. So that seems to be an effective regimen to induce deep MRD negative remissions for patients. One of the toxicities we saw with this regimen was increased neutropenia. We were not using prophylactic GCSF in these patients, but now we are realizing that there is increased neutropenia for these patients. Otherwise, the regimen was relatively well tolerated. So that's the regimen approach we have taken, that for patients with mutated V gene, without deletion 17p, who are young and fit, able to tolerate chemotherapy, where you would think of FCR, our approach right now as part of clinical trial is this regimen called iFCG.
Would you mind if I chimed in with some questions regarding MRD? I have 2 questions, actually. How are you measuring MRD? Are you using flow or molecular technology? And the second question is it important to do MRD testing in the marrow rather than peripheral blood, as compared with, for example, CML, where they are essentially equivalent?
Yeah, so those are excellent questions. So the MRD which we are doing at our institution is bifocal flow cytometry with a sensitivity of 0.01%, and that's what is recommended from the IWCLL guidelines. It can be certainly be done both in the bone marrow and the peripheral blood. Our group, I think the studies have shown that the bone marrow is more sensitive than peripheral blood when you're using the same technology at both places. We have typically have done bone marrow flow cytometry, and that's what the data I reported to you. However, groups such as German Cell Study Group and elsewhere, they have done a lot of work with peripheral blood flow cytometry as well. Maybe others can comment on that question as well.
Yeah, I mean, I think the thing that I would add is the addition of CD20 antibody, and if you're testing for MRD in the setting of giving a CD20 antibody, can skew your results where you'll get a high rate of MRD negativity in the blood where there still is disease in the bone marrow. So if patients are receiving a CD20 antibody, we typically will evaluate in the bone marrow. Unless it's several months after they've completed their CD20 antibody therapy, then things tend to become more consistent between blood and bone marrow. But in general, I think the thought is that bone marrow is a more sensitive place to look. The problem with bone marrow in CLL is nobody wants to have a bone marrow. And so it's, I think in terms of standards of care, the field will move more towards evaluating for minimal residual disease in the blood. And so we're interested in more sensitive methodologies where there may be more of a consistency between blood and bone marrow if you have a higher sensitivity of a test.